Thanks so much. Thanks for the invitation, and sorry to be the bad guy here. We're going to review about MRI biomarkers and how we can trust them or not for treatment decisions. I have no related disclosures, and I'm sorry the overall layout doesn't work, but you know well this stroke of hype on every new technology, and as I'm quite an extreme guy, my personal journey was a little different with a very early enthusiasm on the technique. At those time, the neurologists didn't want the perfusion imaging. I did it. They were not happy about it. And then with the experience of several patients and attending further lecture, I had a very deep disillusion, and I stopped doing perfusion. My lecture 10 years ago looked like this. So I told, well, penumbral imaging is just dead. We don't have to do it anymore. So we'll see why this evolution. And first, we want to define what we expect from those biomarkers very fast, and reviewing one aspect that is overlooked, such as the stroke mimics, for example. Then I will explain how image acquisition and processing choices will impact the variability of MR stroke biomarkers, because you may think that it's robust, that you will get always the same results, but it's not like that, unfortunately. And then we will end with debating the rationale between the current standard MRI biomarkers choices and investigate potential clinical utility of other biomarkers. What are the expected contributions? So a quick word about stroke mimics. It's very frequent. It's at least 1/4 of the code strokes, and in my hospitals, it's half of the code strokes, because we have a very wide definition of code strokes. And of course, in these patients, we don't want to treat them if it's not needed. Sometimes you can have a typical clinical presentation of a stroke with no arterial occlusion. And MRI in those cases might be actually more specific than CT or other modalities. So it's one of the reasons why we chose MRI as a first-line imaging modality in the hospital. So here's an example of a 71-year-old male with aphasia, and you can basically see that the MRI is not normal, but that the diffusion imaging doesn't find any acute ischemic stroke. And if you look at the ASL perfusion, you see a big high signal intensity in this area, and it's actually a seizure on a metastasis that we can see in the T1 post-GAD here. Here's another case of a younger woman that is pregnant. As you can see, or maybe we do not see it that much, but the DWI is completely normal. And the ASL perfusion see a high signal intensity on the left hemisphere with a raised oxygen extraction fraction on the susceptibility weighted images. And it was diagnosed that she had a migraine. I won't review this one in the interest of time. So now we will try to see what do we use and what do we expect from the biomarkers to select patients for acute therapies. Of course, there's a first application that goes yet in the penumbra theory, that is just to help us detect an occlusion that we wouldn't have seen on the MRI. So it's very frequent on small ischemic stroke of medium vessels occlusion that you don't see the medium vessel occlusion on the vascular imaging. And in that case, I found the hypoperfusion maps or the Tmax maps very useful to tell you where there is a large area of hypoperfusion. So maybe you have to be very careful about a small clot. And we use a lot the susceptibility sequence to detect those distal clots. It's a very useful sequence. And on the patients undergoing CT scans, we have the same issues on distal occlusions that might not be obvious on the CTA, and in those patients, perfusion can help us diagnose distal occlusion. The second reason why we want to use biomarker derived from the MRI is that you know all too well the time is brain theory that tells you basically that the core volume is bigger with the time to imaging. But it's a little more complicated than that. And the reality is that we would like to have a crystal ball to just predict whether the infarct core will grow or not if we do not provide treatment. And the ideal biomarker might be maybe more efficient than a crystal ball. And those biomarkers rely on the core and penumbra concept. And I'm sorry, all the text is gone, but the core basically relies on two biomarkers, the CBF, that is the only available biomarkers from the CT scan, and the DWI volume with an ADC threshold usually done. That is the best biomarker that we have on the MRI. And the penumbra volume, you have several candidates parameters, but what we use currently is the Tmax. So a lot of studies, such as studies that have demonstrated the superiority of endovascular therapy, use some kind of data from imaging, and I'm sorry it doesn't appear here, but depending on the study, you can use the core volume or the perfusion mismatch. You have several parameters depending on the studies, but a lot of study has any kind of parameters driving from imaging. And that is because the core volume is actually related both to time to imaging, but also to the infarction growth rate. So when you see the patient at the imaging, you want to have an idea of what is the growth rate, and that is why the biomarkers such as diffusion volume and Tmax are useful. What our neurologists use the perfusion and the mismatch for, they would use it for acute stroke with no mismatch. In those cases, they would maybe skip the treatment. They will use it in medium vessels occlusion, and they use it a lot for large core infarctions to see whether there is additional penumbra. Another ongoing works in our hospital is to see with patients with very mild symptoms but a large vessel occlusion whether it's useful to treat or not. So now we've seen what we expect from those. Let's see the impact of what we acquire. The first impact is the choice between CT and MRI. We don't do a lot of CT in my hospital, but at some occasions we have a patient undergoing CT. This patient was done on CT because she was agitated. And on the CT scan, we can see clearly a large vessel occlusion, and on the non-contrast CT, some mild signs of ischemic stroke. And surprisingly, on the CBF, we don't see any stroke that is above under the threshold, and the hypoperfusion zone is very mild. And the patient got treated and according to the interventionally list, the treatment was successful, but despite that, the final volume was very big comparing to the initial imaging. And I would tend to say that maybe the CBF volume was underestimated, just given what we had on the non-contrast CT. Here's another example of the patient that began with the CT, and as you can see, we had a very small volume, about 30 cc's, and the patient went straight after to do a diffusion MRI where the volume was 70 cc, so a lot bigger. So it is known that actually you have not a very good correlation between the core volume assessed by diffusion, which is a very robust biomarker. We know that it's highly correlated with the final volume, and CTP that tends to be underestimated. Then you have the impact when you do the MRI of the kind of diffusion that you perform, and it's especially true at 3 Tesla, where you can have a very a lower sensitivity at B1000 than at B2000. So I apologize that the image just don't go well, but I swear that you, even with a good image quality, you wouldn't have seen a lot about this ischemic stroke at B1000. And it's true as well for the very small posterior fossa strokes, where we have several acquisition strategy to improve the sensitivity, such as raising the B-value to B2000 or doing higher resolution 3D isotropic diffusion sequences. But when you do those new sequences to improve the sensitivity, be aware that you don't know how the softwares will deal with it, because they're not trained with those data sets. And we noticed that no software deals very well with those high B-values diffusion studies or high resolution studies. And you can see here one of the volumes obtained with ADC threshold and IA-based core volume. And you can see that the results are not optimal because the segmentation is quite wrong from the real ischemic stroke. So finally, given the same acquisition, you can get different core volumes depending on the software you use. And as you can see, I have put several softwares images to demonstrate that some might be better than others. So here's a stroke that is probably difficult to see, and this software detected no ischemic stroke, although we had a left-sided hemiparesthesia. And here's with the Circare AA-based volumetry, you can see, I'm not sure that the diffusion high signal intensity is obvious here, but maybe on the ADC map it's more obvious. But you can see that although you have a few false positive on the other side, the stroke has been correctly identified, and the volume is reasonable to what we can expect. And even from the same software, if you take different ways of processing it, if you compare ADC-based threshold, which is possible with the Circare software, and the IA-based threshold, you can see that you get very different results. And my experience on the ADC threshold is that we have a lot of false negatives, and we also have a few false positives, especially in the posterior fossa and in the cerebellum. What is inside this black box? Because we radiologists don't like black boxes. We like to know what the software does before we can get trust in the values it gives. So basically, the Circare IA core based relies on the ADC maps, on the diffusion signal, on the FLIR signal, and it relies on clinical experts ground truth that was segmented on B1000. So I found these maps usually more reliable than the ADC threshold-based maps, but the formal proof remains to be settled, and I'm aware that some studies are ongoing. And for the hypoperfused volume, it's the same depending on the software that you use, and even if you use Circare software, depending on if you use the Tmax algorithm or the IA hypoperfused volume, you will get different results. And my experience is, again, that hypoperfused volume is usually more accurate. So a lot of software variability among hypoperfused volume. Here's an example. You can see that the stroke volume was 0 in this software, and the Tmax is just nonsense. I don't know what happened here with the software, but I would say it's not reliable at all. And here's the same patient. You can see that the stroke was quite obvious on diffusion and ADC, and that you have a raised Tmax in some part of the territory. So I don't understand why the maps were wrong in the first software. And here's the IA-based results for core and hypoperfused volume, and I find it a lot more trustable. So who is right when we have two softwares giving very different volumes? Who is right? And when you talk to some vendors, they tell you, well, I'm right, I'm used in several clinical studies, you know, so you should use it too because I'm right. But what I find is being part of a successful study about a therapy doesn't make the software validated. So I think there is a crucial need of validation studies on each software package. And the difficulty we have is that some softwares do not want us to do those studies. So to end, we will debate the rationale between the current standard biomarkers choices and foresee new biomarkers, and hopefully Alexandre will tell us more in the following lectures. So what we want is to assess score. So to assess score in CT scan, we are RCBF that are used a lot, but we know that it's underestimated. That's what we've seen in the previous slides. We've seen that the ADC and the diffusion volume is a better biomarker. It's more validated than other biomarkers, and it's quite reliable because it's highly correlated to the final volume. The penumbra evaluation is a little more complicated. A few years back, when CERCARE didn't exist and RAPID didn't exist, I used this software, Assist Japan, that was a free software, and it was always hard to select which parameter you would like to assess the penumbra, and depending on the threshold you took and the parameter you chose, whether you take regular MTT, the convolution techniques, you would have very different results, and results would be correlated or less correlated to the clinical outcome. So there has been a lot of debate, and finally we tend to use the Tmax because it's what's used in a lot of studies, but I want you to be very critical on those parameters and why we chose those parameters. So if you get back to the Tmax, where does it come from? In which publication has it been described for the first time, and why did we choose this one? So if you get back, you have a great study. The diffuse study was a great study, but in the end, this Tmax threshold has been done from 33 patients from this study. So does it make it reliable, validated? Is it really the best choice that we have for penumbra? I don't know. I don't know, honestly. And we know that there's a gray zone. That's an old scheme, but I like it. You know that not all the diffusion lesions will correspond to irreversible tissue damage. Some part of the diffusion high signal intensity that will be taken into account in your diffusion volume will not actually be irreversible tissue damage. And it's important to know, especially for large core strokes, where some of the tissue might still be salvageable. And with the same concept, part of the penumbra may not really be at risk. It might be oligemia that has a perfusion delay. So with those volume, you have to think of them as a gray zone. Maybe it's not completely matches the penumbra theory, and I think the penumbra theory has to be seen as something with a gray outline rather than black or white and all positive or negative. So that comes to new biomarkers that came from PET imaging. We know that the stroke model is far more complicated than just a delay of perfusion and a low CBF. So biomarkers coming from PET, we have probably the thinking that they might be very useful, but we do not use it. So why don't we use it? Because it was very complicated on MRI to get OEF maps. For example, in the past years, we had to do dedicated Q-bolt sequences, QSM sequences. It was very long. It's 5 to 6 minutes. We cannot do it in an acute stroke settings. And that's why I find that being able to get those parameters from the regular perfusion is really a game changer. And I won't spoil Alexandre's presentation, but this is a case that we have in our hospital. You can see in ASL a wide hypoperfusion, and you can see this OEF that is raised in the left hemisphere in this migraine patient, and you can see the correlation with susceptibility where the vessels look bigger because the oxygen extraction is superior. And then, if I have some time, yeah, what about the biomarkers that we don't think of? We think of the biomarkers that comes from the perfusion, that comes from the PET, but maybe some of the biomarkers are overlooked with our softwares. And I want to underline that we do not use a lot the informations from the clot. And the clot is indeed very important, especially if you're gonna go to the angio suite after the MRI. The interventionalist will want to know whether the clot can go without him, whether the clot will be difficult to have or not. So I think it's an information that radiologists, diagnostic radiologists sometimes overlook. And well, for assessing the pipes, we might have several biomarkers that would be very useful. One of the biomarkers is already published. It's the length of the thrombus. The longer the thrombus is, the harder it will be to intravenous thrombolysis to make it go away. So we know that if we have a long thrombus, we can get the patient to the angio suite straight away. It won't probably go away with medical therapy alone. And what I find very interesting, we do susceptibility imaging instead of T2 star since 10 years. And we do a susceptibility with several echoes, and still it's very fast. The deal with our neurologist, it has to be as fast as a T2 star. So we made it last 50 seconds. So the image quality is not very nice, but what you can see is when you get to the longer echoes, then you get more susceptibility effect, and the thrombus gets darker. And actually what is very interesting is from one patient to another, the thrombus doesn't get darker as fast. So maybe it's another way, a quantitative way to see the susceptibility vessel sign that might be able to reliably tell us whether it's a red clot or white clot. So the take-home points that will not appear here because, oh yeah, it will appear. So there's a Russian proverb, trust but verify. I think it suits very well to the biomarkers topics. So for diagnostic neuroradiologists and neurologists and interventionalists, I want you to carefully evaluate the validity of quantitative results from commercial software. You don't have to assume they are always accurate. Sometimes they will not. Obviously, my lecture is biased. I presented cases that are worst case scenarios, which is a little unusual in those conferences. And be reassured, sometimes it works very well. But yeah, always check it. And I want to reflect this in the radiology report, whether the volume that they have on the packs is reliable or if I think it is not. And keep in mind that no imaging biomarker truly captures what it's meant to measure. So I hope we will make progress from this, but that's my point of view for now. Thanks for your attention.
Thank you very much for this provoking but also very important contribution. I should say that Julien also sit on our scientific advisory board, and having critical people, I know that the best scientists are those that were extremely critical of the data they have and how they can make it better. So I think this is really important to discuss. So questions, comments? I actually have a question for you and probably for people in the audience, and that is that, you know, of course, software works best if they get high quality images in essentially and high quality data. And I wonder if you or anyone else has, you know, experience with, you know, quality control to, you know, go back and look at the data and see, you know, were there artifacts, were there, you know, changes that, you know, could explain why these sort of off-the-shelf software packages sometimes fail.
I don't know if someone in the audience has an experience in it. We do quality control systematically. Even if we find that the software results are good, one of the first steps of a good interpretation is a quality control. And actually, we want even to that the technologists actually do their jobs and do the quality control to be to have the opportunity to repeat the sequence when it's not good enough. So usually they do it. Sometimes they don't do it. But yeah, I think the quality control should be systematic.
Yeah. So if you have a message to the audience here, would that be to get together and really, you know, look at biomarkers critically, get big volumes of of data, analyze them, and report how often does it fail and how often does it not, you know, provide useful information? What would be your message?
Yeah, I think nowadays our need is to have a well-done study assessing all the softwares and all the technologies to get those biomarkers and comparing them. I think it's crucial for us to know, and it's crucial even commercially to know what we must favor to buy. And another thing is that even with a perfect software, sometimes I think we will have bad results. So my message is to verify those maps. Don't take them for granted.
No. And big repositories of data that can then be analyzed with different software packages is ideal there. And that works in many image processing communities, but as you alluded to, there are difficulties also in
Yeah, you're right. One of the reasons we think that the software works well in some sites and do not work well in some other sites is that softwares might be trained on one or two devices, and once you get to another brand of MRI, to another field strength, you might not get exactly the same result, the same ADC, the same artifacts at the same place. So I think it's crucial that we have a large database representing all MRI vendors, all field strength, and that the training of the softwares are refined with those.
Yeah. Thank you so much.
You're welcome.
We missed a question. Sorry, you're not off the hook yet. Sorry.
I don't know if it was that important, but just a small comment. If I understood you correctly, you said that you find that in CT perfusion, CBF was the best indicator for core, for infarct core. from my personal experience, but I can speak only for the deconvolution algorithms from Siemens and Toshiba. In my cases, CBV was the best correlator for infarct core because that's an indicator of the territory with autoregulation breakdown, and that was almost a perfect match with diffusion MRI.
To be completely honest, my experience with CT is very poor because we do, I don't know, 10 CTs a year in patients that could not go to the MRI. So I rely on what's published in the literature where you find more CBF based thresholds. And maybe that's coming from the PET literature, I don't know. My experience is not enough, and you're probably right if you go with the CD. I find it more easy to interpret the CBV maps indeed when I do the CT. But I'm not sure of that because I don't do it often enough.
Okay, thank you. Then is my, yes.